Medurstand Understanding Medicine.
I'm Professor Aziz-ur-Rehman, and in our series of lectures on various types of anemias, today we are going to discuss thalassemias. Thalassemias are fairly common conditions, not rare at all, and they often come in the differential diagnosis of anemia. Some basic concepts were discussed in my earlier lectures, the lecture on approach to anemias and interpretation of CBC and differential diagnosis of common anemias. So it is very strongly recommended that if you have landed up here directly, you go back and watch those videos so that you can understand this part better. Because I have already covered those components earlier, so I will be skipping those details. So that makes it even more important that you watch those videos before you watch this one. I think we first need to understand the molecule of hemoglobin. The hemoglobin molecule consists of two sets of chains, two alpha chains and two chains which may be beta or gamma or delta. Alpha chains are absolutely essential for any hemoglobin molecule, whereas beta chain is part of hemoglobin A or A1. It is actually, previously it was called hemoglobin A, but now we call it A1 to differentiate it from hemoglobin A2. Hemoglobin F is present in fetus in much greater concentration, but after birth it starts reducing in quantity, but in adults it still stays in very small quantities. Hemoglobin A2 is also another type of hemoglobin which is present in very small concentration in adults. But these three different hemoglobins, they vary from the beta chain or the gamma or delta chain, whereas alpha chain is common to all hemoglobins. And in the center of a chain there is heme molecule, and you can see this is the structure of heme, and right in the center of heme there is iron molecule, because iron cannot stay stable and cannot is toxic, so it has to be kept hidden right in the middle of hemoglobin molecule. Now let's discuss hemoglobin related disorders. We have various types. These disorders may be related to RBC mass, and RBC mass may be reduced, and that would result in various types of anemias. And if RBC mass is increased, that would cause a condition called polycythemia. We will have a separate lecture on polycythemia. Then we have some disorders related to hemoglobin molecule itself. The problem may be qualitative. That means that the hemoglobin molecule is qualitatively different than normal. This would be referred to as hemoglobinopathies. And there are various types, and this will be covered in separate lecture. Then we have quantitative defects. By this we mean that hemoglobin is structurally normal. The chains, there are different chains, chains are structurally normal, but alpha chain or beta chain may be reduced in quantity depending upon which type of thalassemia we are talking about. For example, in alpha thalassemia, alpha chain will be reduced to various extent depending upon which subtype of alpha thalassemia we are talking about. As a result, beta chain will be in relative excess. That unbalanced beta chain will cause problems. Similarly, in beta thalassemias, there will be relative excess of alpha chain, and that will also cause problem. And this will be discussed in the subsequent slides. Then the problem may be related to the heme part of the hemoglobin molecule, and this would cause various types of porphyrias. So we are these days discussing various types of anemias, and one of those anemias is thalassemias, which we will be discussing today. Okay, so we have these are three hemoglobins which are present in healthy adults. Most of hemoglobin in adults is HbA1 or simply HbA. This is 90% of our hemoglobin is this one. But about 1 to 2% may be hemoglobin F. As I told you earlier, hemoglobin F is normal hemoglobin in fetus. And then we have hemoglobin A2, again about 1 to 2%, which is present in adults, and if you have this ratio, this would be considered normal. And let's see what is hemoglobin A1. It is actually 2 alpha chains and 2 beta chains. If that is the case, alpha chains and beta chains equal in quantities, that would be hemoglobin A1. And in hemoglobin F, we have 2 alpha chain, but instead of beta chain, we have gamma chain. So 2 alpha and 2 gamma. That will make fetal hemoglobin. And then we have hemoglobin A2, 2 alpha chains and 2 delta chains. Alright, so please note down, alpha chain is present in all normal adult hemoglobins. But the other chain may be beta in case of hemoglobin A1, gamma in case of hemoglobin, fetal hemoglobin, and delta in case of hemoglobin A2. So these ratios will vary in various types of thalassemias. Let's first classify thalassemia. There may be beta thalassemia, and beta chain needs only one gene. So the variety of thalassemias will be relatively less in beta thalassemia. There may be thalassaemia minor, also called thalassemia trait, and then there may be thalassaemia major. There is actually thalassemia intermedia also, but I'm not going to discuss that in detail. I'm just going to give you the basic concepts about thalassemia. If you are interested in this subject, you can refer to the textbook and read more about it. Thalassaemia minor is actually a very mild disorder, many times asymptomatic and many times detected only on screening. Patient may not have any problem also at all. Thalassaemia major is a serious disorder and mostly is present at the time of birth, and sometime a dead fetus is born, and that of course is a serious thing. Then we have alpha thalassemia. Alpha thalassemia is because of the abnormality in the alpha chain, and alpha chain requires two genes. So there would be much more diverse situation here. On one hand, there may be absolutely healthy looking but carrier. They have abnormal gene, but their HB may be normal, and everything you check, it may be normal. Then thalassemia minor, thalassemia major, and then hydrops fetalis. Now, where all four genes, so one gene abnormality, two gene abnormality, three gene abnormality, and then all four genes are abnormal. So you have four different grades of thalassemia, alpha thalassemia. This is the genetics of beta thalassemia. I think it will make the subject a little interesting. Suppose these are two individuals, male and female. This is unaffected carrier, a male who's a father, and unaffected carrier, mother. Since this is a recessive disorder, so both have one recessive gene. That is why they are healthy. Otherwise, except that they have slightly low HB. Both have thalassemia minor. Thalassemia minor people can grow up to adult age and they can produce children. Now, when they mate, there are, suppose with every pregnancy, there is one of these four possibilities. Now, this R capital means healthy gene, R, the lowercase r means the defective genes. So both have one healthy gene, one defective gene, both parents. So there are four possibilities. Both healthy genes may produce an absolutely unaffected fetus, which would not even be carrier. Both unhealthy genes may result in thalassemia major. And then two babies will be similar to this one, thalassemia trait, one normal gene, one abnormal gene. So if uh, in a couple both have thalassemia minor, there is 1 in 4 chance that there will be a thalassemia major, 1 in 4 chance that there will be absolutely normal healthy child, and 2 in 4 chance that there would be a thalassemia trait. So this is the genetics, and the genetics of alpha thalassemia is more complex. This is the blood picture of thalassemia minor. You can see that these cells are small and hypochromic. So a very typical hypochromic microcytic picture. But most of the cells are more or less the same size. So there isn't much variation in the cell size. So RDW will be narrow and isocytosis will also be limited. You can also see these teardrop cells. You can see these target cells. This one is a target cell. So this one is also another cell which can be called target cell. So these are the abnormalities we see in patient with thalassemia minor. In thalassemia major, you have much more abnormal size and abnormal shape cells, much more hypochromic and many more target cells. Now, thalassemia major, I normally practice adult medicine and do not see these children, but this is the picture of a child with thalassemia major. You can see this frontal bossing. The bones are hypertrophied because of the expanded bone marrow. Now, this is the picture once bone marrow expands, and this crew cut type of appearance, this very characteristic X-ray appearance is the result of bone marrow expansion, because bone marrow tissue comes out of the bone and along the capillaries, and this kind of picture is made. Very, very characteristic of thalassemia major, because this kind of picture can develop only if the disease develops in the childhood. Now, prevention of thalassemia, first of all, pre-marriage and pre-pregnancy counseling. If one of the parents has thalassemia trait, the other one has no thalassemia trait, then there is no problem. There are some chances that some of the children, some of the born babies would have thalassemia trait. That's not a big deal. But if both the parents have thalassemia trait, then you need to sit with the parents and tell them that there is a 1 in 4 possibility that you would have thalassemia major or hydrops fetalis child, which would result in prenatal death or death immediately after birth. So luckily prenatal antenatal screening is now available. If there is an indication that the fetus is thalassemia major, the pregnancy may be terminated. Pre-marriage counseling means that if somebody is looking for a proposal, it is normally recommended that the cousin marriages should be discouraged, because thalassemia trait runs in the family. So there is a chance that if one person has thalassemia trait, his or her cousins would also have thalassemia trait. But it is not necessary, but there is a chance. So there are two possibilities. One is just to make a general rule not to marry a cousin, first cousin. But another possibility is if you have a good proposal and you want to marry, I think both partners can be screened. If they both have thalassemia minor, still they can marry, but then of course they would have to have this antenatal screening. So these two are the ways to prevent thalassemia from happening. Diagnosis of thalassemia is simple. We have discussed it partially early, but now I'm going to discuss it again. Family history is important because thalassemia runs in the family. Please note down, it is quite possible, and I've seen it number of times, somebody who is diagnosed with thalassemia does not give family history because family members never got screened properly and they never knew that they had this thalassemia minor. But if you screen the parents, they would be having the abnormality, or maybe there is already a known family history. Anemia is usually mild in thalassemia minor, but depending upon which type of thalassemia you are talking about, it would be severe also in thalassemia major. Splenomegaly may be present because splenomegaly is because of hemolysis, and these patients, they have fewer RBCs, and RBCs are also very vulnerable to rupture. So they have, most of them, they have at least thalassemia major, they have splenomegaly. And on CBC, they would have hypochromic microcytic anemia with the normal RDW. Iron deficiency anemia, which is extremely common, and thalassemia, which is much less common but not very uncommon, both have hypochromic microcytic picture. But in iron deficiency, you would have a wide RDW, meaning that although all cells are smaller than normal, but the variation in cell size is significant. And you of course need to rule out iron deficiency before you make a formal diagnosis of thalassemia. And then there may be target cells, and there may be the ultimate test for thalassemia is hemoglobin electrophoresis. Electrophoresis is a technique where we differentiate various types of hemoglobins and see if hemoglobin, the various types are present in the normal proportion or that proportion is changed, and that gives us the this is the electrophoresis. The basic principle of electrophoresis is that whatever you're going to do electrophoresis on, in this case hemoglobin is applied on this strip here, and there is a current, the voltage, for example, positive here, negative here, or negative here, positive here, and you know negative attracts positive and positive attracts negative. So based on that simple principle of physics, and with time this hemoglobin molecule will move this way, and after a specific time we will see that they settle somewhere. So in normal healthy people, hemoglobin A, which is the thickest band, they will come and settle here, and hemoglobin F is here, and hemoglobin A2 is here. And you can see from the thickness of the bands that hemoglobin A is in the majority. Mostly it is hemoglobin A, but we also have hemoglobin F and hemoglobin A2. Now in thalassemia, this is what happens. Now hemoglobin A is reduced. That is why, because they're anemic, hemoglobin A is reduced. Hemoglobin F is much increased proportionately depending upon which type of thalassemia. This is perhaps thalassemia major, because increase in hemoglobin F is very marked. Actually, hemoglobin F is more than hemoglobin A. In adults we see thalassemia minor, so then this band would be thicker than this one, but not this thick. And in this picture, this is hemoglobin A2. Perhaps hemoglobin A2 is not present in this case, but it may be increased. So in hemoglobin electrophoresis, in beta thalassemia, what actually happens is that hemoglobin A is reduced and hemoglobin F and hemoglobin A2 both are increased. Normal percentage is about 2% and they would be increased on to 3%, 4%, 5%. So this is the principle of electrophoresis. We do this test to determine if hemoglobin F or hemoglobin A2 are increased. Now I would like to make a point here. You know that in beta thalassemia, beta chain may be replaced by delta or gamma, resulting in hemoglobin F and hemoglobin A2. But in alpha thalassemia, alpha chain is indispensable. Alpha chain cannot be replaced by another chain. So in alpha thalassemia, you will not see this abnormality on electrophoresis. So electrophoresis is only helpful in the diagnosis of beta thalassemia. For alpha thalassemia, we need more sophisticated tests. The diagnosis of thalassemia, first of all, there may be family history, but let me make a point that family history is not always available or not always known. Of course, one of the parents must have thalassemia trait, but it is not always known. So sometimes we have to go back to the parents and screen them. But if the family history is positive, then the diagnosis will become easy. Depending upon which type of thalassemia they have, is it thalassaemia minor or thalassaemia major, there would be a deficiency of HB and these people would have anemia. Most adults with thalassaemia minor, they have hemoglobin around 10, 11 and they may not be symptomatic, but in thalassaemia major, of course, there would be much more anemia. And in some cases, especially in alpha thalassemia, it is perfectly possible to have hemoglobin which fall within the normal range. These are cases of thalassemia carrier healthy trait. Splenomegaly may be present. There is much prominent splenomegaly in thalassemia major, but some splenomegaly may be present in thalassemia minor also. Then there would be hypochromic microcytic picture on CBC. The commonest cause of hypochromic microcytic picture is iron deficiency. So I think we need to rule out iron deficiency before we proceed further with the investigation of thalassemia. Iron deficiency remains very important, very common cause. You would have some idea on the CBC. For example, in thalassemia, there may be widened RDW. In thalassemia, there is narrow RDW, whereas in iron deficiency anemia, RDW may be increased, indicating anisocytosis. In thalassemia, typically, all cells are hypochromic microcytic and variation in cell is not much. In beta thalassemia, the ultimate test is hemoglobin electrophoresis. Now what we want to determine is that hemoglobin A2 and hemoglobin F levels are increased in beta thalassemia. Because hemoglobin A2 and hemoglobin F, they have alpha chains like hemoglobin A or A1, but the alternate chain is beta or not beta, gamma or delta. So gamma or delta chains are increased, resulting in increased level of A2 and F hemoglobin. That would not apply to alpha thalassemia because alpha thalassemia, alpha chain is indispensable. Alpha chain cannot be replaced by another chain. So if there is alpha thalassemia, there would be anemia, there would be some other abnormalities, but hemoglobin A2 and hemoglobin F will also not be increased because these two hemoglobins also need alpha chain. So because they also need alpha chain, they will not be increased. So that means that hemoglobin electrophoresis would not be helpful in the diagnosis of alpha thalassemia. Of course, if you have first ruled out iron deficiency, then you have ruled out beta thalassemia, then the diagnosis of alpha thalassemia in patient with hypochromic microcytic anemia would be very likely, but you would need a special test, a DNA analysis, which is not routinely available but can be done. The treatment of thalassemia, I think whenever the diagnosis of thalassemia is made, first of all, we need to sit with the patient and counsel him and explain him what thalassemia is. If it is thalassaemia minor or thalassemia trait, then we need to explain to the patient that a normal life expectancy and a normal healthy life is possible. But if this patient marries another person who also happen to have the thalassemia trait, then there are chances that in children 1 in 4 would have thalassaemia major. So it is recommended that these patients should not marry in the family because this thalassemia trait runs in the family. Or if they do want to marry somebody in the family, they both should be screened. It is not that that thalassemia minor cannot marry another person with thalassemia minor. If they do marry, then there's a 1 out of 4 chances that the child would have thalassemia major. Luckily, screening is possible, antenatal is possible, and if one of the fetus has thalassemia major, the pregnancy can be terminated. Iron is generally contraindicated, and especially in thalassemia major, because these people, they have excess of iron. They may be consuming normal amount of iron and they may be actually taking iron supplements, but since iron is not utilized in the hemopoiesis, or it is because of hemolysis more iron is released, they may have excess ferritin, and not only they do not need iron, but in some cases iron has to be removed. But I have seen a number of patients, this is my personal experience. There are people who are known cases of thalassaemia minor, but they have been told not to take iron supplements, and they may actually have developed iron deficiency in addition to thalassemia. Now, if that is the case, you can certainly give iron. Not only it is not contraindicated, in fact, it is absolutely essential because you can correct at least some of the anemia with iron supplements. So after the diagnosis, you need to have their iron studies. If iron is in excess, then of course no iron. If they have iron deficiency, then some iron may be given. Folic acid and vitamin B12 supplements are also recommended because of the fast erythropoiesis. Bone marrow is hyperplastic. Bone marrow activity is very fast. Although cells are being destroyed in the spleen, but more cells are being produced. So these patients, they need folic acid and vitamin B12 supplements. Otherwise, there is a risk that there would be additional deficiency of folic acid and vitamin B12, further aggravating anemia. Blood transfusions are indicated as first line of treatment if bone marrow transplantation is not possible, but we need to set a threshold. Most patients with thalassaemia minor, they do not need transfusion unless they have to undergo some surgical procedure, and 1 or 2 transfusions may be needed. I think one should try to control one's temptation of giving blood transfusion unless it is absolutely essential. In thalassaemia major, they would of course be needed. Unless they can go for stem cell transplantation or bone marrow transplantation, transfusion may be needed, but transfusions have many problems. One problem is iron overload, the other problem is volume overload, another problem is development of isoimmunization. So every time blood transfusion is given, the improvement in HB is less and less. And then sometime these patients need to be given these chelating agent. chelating agent is something which can remove some iron, some matter in the body, and this is traditional drug deferoxamine. This is given as subcutaneous infusion, and this is one is oral form, not available in our country, but of course this would be very convenient. One pill to be taken every day, and slowly iron will be removed. The extra iron will be removed, because extra iron can itself be a medical issue. Then bone marrow transplantation and stem cell transplantation would be, of course, very good possibility if the facility is available. Bone marrow transplantation is a technique. I think I have few slides I'll show you, and then stem cell transplantation, that means if you can isolate those cells which will result in bone marrow, they can be also transplanted. Gene therapy and gene editing is the treatment of future. Currently, to my knowledge, they are not available. Now let's go through this investigation of thalassemia. It's like a revision. Hemoglobin and hematocrit, what do you think? Of course will be reduced. In Thalassaemia minor, they are reduced to only a small extent, like HB may be 10 or 11. But in thalassemia intermedia and thalassemia major, they could be like 4 gram, 5 gram, or even less. MCV, MCH or MCHC, particularly MCV, is reduced because these patients, they have hypochromic microcytic picture. And in the peripheral smear, you have two major abnormalities. Of course, you have hypochromic microcytic picture on the peripheral smear also, but there may be target cells and there may be basophilic stippling. This is also a feature of thalassemia. And if you estimate their iron and you ferritin, they may be normal or high. In some patient, iron may be normal, in some it may be high, and I have told you that because of nutritional deficiency, some may actually have deficiency of iron also, but that is not actually part of thalassemia, that is an additional abnormality. If you do hemoglobin electrophoresis in beta thalassemia, hemoglobin F and hemoglobin A2 will be high, but in alpha thalassemia, hemoglobin electrophoresis would not show this abnormality because hemoglobin F and hemoglobin A2 also need alpha chain, and alpha chain is deficient in alpha thalassemia, so electrophoresis would be normal in alpha thalassemia. So we need DNA testing to confirm the diagnosis of alpha thalassemia. In bone marrow will be hypercellular, and if you do the reticulocyte count, it will be increased because in patient with thalassemia there is always a component of hemolysis and new cells are formed. Although new cells are formed, but since their lifespan of RBC is reduced, these patients are still anemic. So that was all about thalassemia. I basically focused on alpha thalassemia or beta thalassemia minor because I deal with adults. So those who are interested in learning more about thalassemia major, and they should refer to some textbook of medicine. This is Professor Aziz-ur-Rehman from Medurstand, and I really look forward to see you in my next video. Thank you very much.